Good morning, everybody. How is everybody today? This is Dr. Cradle, and we're going to get started here in a couple minutes covering this next chapter. This is chapter 9, respiratory emergencies. So please bear with me for just a couple. Just got to get everything done to get done. Here we go. A little better there? I think so. Well, our national standards for airway management, respirations, and artificial ventilation. This is going to be a time of applying knowledge of general anatomy and physiology to the patient assessment and management in order to assure a patent airway, adequate mechanical ventilation, and respirations of patients of all ages. So what's patent mean? Patent means open, O-P-E-N, open, an open airway, an airway that's allowing oxygen to go in and out during ventilation. So that's what it's just talking about there, is just to the management of in order to assure a patent or open air airway. That's what we're talking about. We're talking about airway anatomy, airway assessment, and different techniques for assuring a patent airway or an open airway. We're going to review the anatomy of respiration. We're going to review respiration, the anatomy of the respiratory system, psychological and pathophysiological aspects of respiration, pulmonary ventilation, oxygenation, and respiration. So we're going to be talking about ventilation, oxygenation, respiration, which is going to be external, internal, and cellular levels. We're going to talk about the assessment and management of adequate and inadequate respirations, supplemental oxygen therapy, and artificial ventilation. We're going to talk about assessment and management of adequate and inadequate ventilations. Artificial ventilations, us breathing in with a bag valve mask for these patients. We're talking about minute volume, alveolar ventilation, and the effect of the artificial ventilation on the cardiac output. We're talking about some pathophysiology. It applies to the fundamental knowledge of the pathophysiology of respiration and the perfusion of the patient assessment and management. So, as you can see it a little bit better. Let's do a little bit of an introduction here. When the ability to breathe is disrupted, what's going to happen with a patient? What do I mean by the ability to breathe is disrupted? Oxygen delivery to the tissues and cells is compromised. It's not getting like it's supposed to. It's not doing what it needs to, and the air is not getting there. It's going to cause problems, right? Vital organs may not function normally when they're not getting air. Brain tissue will begin to die within 4 to 6 minutes. That's not a good thing. As oxygen reaches the body's tissues and the cells through the breathing and circulation, you have, during inspiration, oxygen moves from the atmosphere into your lungs. Oxygen-rich blood is pumped through the body to the heart, by the heart, You must be able to locate the parts of the respiratory system and understand how this system works to do the job in EMS, to do the job of an EMT, advanced EMT, or a paramedic. It's one of the basic skills is airway management. It starts with us as an EMT, goes to the advanced practicing EMT, and then the paramedic. So it's a skill we have to know. We have to know it by heart, inside and outside. We've got to get it down. Anatomy of the respiratory system. As you can see it in your book there, and we're going to go through it. It's a nice picture that you might want to know that picture for a quiz. You will see that picture again probably. The respiratory system consists of all structures that make up the airway and help us breathe and ventilate. The airway is divided into upper and lower airways. The upper airway consists of nose, mouth, your jaw, your oral cavity, your pharynx, and your larynx. Its main function is to warm, filter, and humidify air as it enters the body. Your pharynx is a muscular tube extending from the nose and the mouth to the level of the esophagus and the trachea. It's composed from top to bottom of the nasopharynx, oropharynx, and larynx. Nasopharynx, formed by the union of facial bones, warms and humidifies air as it enters into the body. It's a nice picture there. As we go and talk about different airways, this is going to be very, very vital of some of your landmarks you're going to be seeing in somebody's mouth to intubate them, or to do a King airway, or to even do an oropharyngeal airway and a nasopharyngeal airway. Oropharynx, posterior position of the oral cavity, enters the respiratory system and the digestive system. This is superior to the larynx. Superior to the larynx is the epiglottis. Another picture you need to become aware of. The hanging down thing, the uvula. You hear it a lot of times. That hanging down thing in the back of my throat is the uvula, your tongue. And over there you have another good diagram that you probably will need to know. You will probably need to know these diagrams. Whether you get tested on this diagram by me or by other people in the future, you will probably need to know these diagrams, so please learn them. Your larynx. It's a complex structure formed by many independent cartilages structures. Marks where the upper airway ends and the lower airway begins. Your larynx is also the thyroid cartilage forms a V-shaped anteriorly, and the cricoid cartilage forms the lowest portion of the larynx. The glottis is the area between the vocal cords. The function of the lower airway is to exchange oxygen and carbon dioxide. This is going to include your trachea, your bronchial, and your lungs. Your bronchi, excuse me. Trachea is the conduit for air to enter into the lungs. It divides at the carina into two main stem, bronchial right and left. Your bronchi are supported by cartilage. Your bronchi distribute oxygen to the lungs. Here again, another picture you will probably need to know. As you see, this is the carina. This is come down the windpipe or the trachea, and it comes to the area here where right and left main stem veer off. This is the carina. That spot right there is the carina. Sorry, right there. Trachea also, bronchioles are made of smooth muscle and dilate and constrict as oxygen passes through them. Smaller bronchioles connect to the alveoli. The way I remember alveoli is ravioli or alveoli. Got to be in my head sometimes. So the smaller bronchioles connect to the alveoli. Oxygen is transported back to the heart and distributed to the rest of the body. It's your trachea, your vena cava, your aorta, your bronchus, and your lungs going back and forth to carry the blood. The heart is the heart and great vessels, the vena cava and the aorta, are also contained within the thoracic cavity. The mediastinum is the space between the lungs, and it contains the heart, the great vessels, the esophagus, the trachea, the major bronchial, and many nerves. So, I did a really fast review there. Please know that you need to be able to be aware, and you need to know that information, know those landmarks, and know that parts of the body that you'll need to have for the upper and the lower airway. Now we're going to go into the physiology of breathing. Respiration and the cardiovascular system work together. They ensure a constant supply of oxygen and nutrients are delivered to the cells. The other job they do is remove carbon dioxide and waste products. There's a difference between ventilation, respiration, and oxygenation. You'll need to know these three. Ventilation is the physical act of moving air into and out of the lungs. This is how you and I breathe, move in and out. This is how we use a bag-out mask. That's ventilation. Respiration is the actual exchange of oxygen and carbon dioxide in the alveoli, as well as the tissues of the body. Then you have oxygenation, which is the process of loading oxygen molecules onto the hemoglobin molecules in the bloodstream. So you have ventilation, respiration, and oxygenation. Those are three terms you will see over and over and over again in your career in the medical field. Ventilation is the physical act of moving air into and out of the lungs. On inhalation, since this is an active muscular part of breathing, the diaphragm and the intercostal muscles contract. The diaphragm acts as the voluntary and involuntary muscle. Lungs require the movement of the chest and supporting structures to expand. Your partial pressure is the amount of gas in the air or dissolved fluid over the blood. Oxygen and carbon dioxide both diffuse until partial pressures in the air and the blood are equal. Nice picture there of your diaphragm contracting, letting air go into the lungs. And as your diaphragm relaxes, it pushes the air back out of the lungs. Excuse me. During inspiration, focuses on the delivering of oxygen to the alveoli. Your tidal volume, your dead space, minute volume, vital capacity, and residual volume, some different terms you might want to be aware of for a test or anything coming up. Then we have exhaling. This does not normally require muscular effort. It's a passive process. The diaphragm and intercostal muscles relax. Smaller thoracic compresses the air into the lungs. As you exhale, air can enter and leaves the lungs only if it travels through the trachea. Nice picture there. Come down your nose and in your mouth. Into your trachea, into your lungs. Excuse me. Regulation of ventilation is primary by the pH of the cerebral spinal fluid. This is directly related to the amount of carbon dioxide in the plasma. Failure to meet the body's needs for oxygen may result in hypoxia. Hypoxia is word that you guys hopefully will have picked to use as your vocab words for this chapter. And we'll talk about that in a couple minutes. Patients with COPD or chronic obstructive pulmonary disease have difficulty eliminating carbon dioxide through exhalation. Oxygenation. This is the process of loading oxygen molecules onto the hemoglobin molecules in the bloodstream. This requires an internal respiration to take place. This does not guarantee, however, the internal respiration is taking place. Just because you have external respiration, which is the blood, carbon dioxide offloading in the lungs, oxygen onloading, and then taken throughout the body. But your internal respiration, which is down the cellular level at your fingers and your toes, is not always going to be guaranteed by oxygenation. Oxygenation is just getting the oxygen to them through the blood. However, it does not guarantee that the internal respiration is taking place, which is the cellular process of offloading oxygen and unloading carbon dioxide at the cellular level to be taken back to the heart and to the lungs. Respiration. This is the actual exchange of oxygen and carbon dioxide in the alveoli and the tissues of the body. So you have your external respiration, which happens in the alveoli, and your internal, which happens in the cellular level. Cells take energy from nutrients through metabolism. I know this is very, very fast. We've got to get through this stuff, guys. And if you have questions, please send them to me, either on Edmodo or on my email address at ccredle, CCREDLE, at WPCSS.net. And I will get back to you as soon as I can there. So we've got to keep going here. It's a nice picture. This is going to be external respiration, which is also known as your pulmonary respiration. Breathes fresh air in the respiratory system, exchanges oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. This is happening here. That's what's going on. It's that little box here and here. That's called external respiration. Then internal respiration, like I was talking about a couple minutes ago, is the exchange of oxygen and carbon dioxide between the systemic circulatory system in the cells. This is going on in the cells of your body, in your fingers, in your toes, in your earlobes, your knee, down the cellular level. This is where we want to make sure we get oxygenation down to the cellular level to make sure that this patient is not going into shock. Shock is inadequate tissue perfusion or inadequate tissue oxygenation. So if we're losing oxygen down here and not getting it, then this patient's going to go into shock, which can cause a whole lot more problems. We'll talk about that more in another chapter. So we have External respiration, which is actually happening in our lungs, is not outside of our body, but it's not external respiration, it's pulmonary respiration, which is taking the gas exchange taking place in the chest. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells. And you see that's your fingers, your toes, your earlobes, and anywhere else that's happening. Eventually, every cell will die if deprived of oxygen. Time is crucial. Depends on what book you read. In our book here, it says 1 to 3 minutes. You have cardiac irritability, which means your heart's going to get mad. It's going to start throwing off PVCs and throwing off different things, saying, "Hey, I'm mad. I need some oxygen. Give it to me, or else I'm going to die." 1 to 4 minutes, the brain damage is not likely. 4 to 6, brain damage is possible. 6 to 10 minutes of somebody being without oxygen, brain damage is very likely. More than 10 minutes, the patient will start having irreversible brain damage. So there's some pathophysiology of respiration. Factors of the nervous system. You have chemoreceptor monitor levels in your body for oxygen, carbon dioxide, hydrogen ions, pH of your cerebral spinal fluid. These all different things provide feedback to the respiratory centers. Ventilation and perfusion ratio mismatch. We're only going to run through this very, very fast. Ventilation is what? That's air going in and out. Perfusion is what? Your blood going round and round and getting your oxygen down to the cellular level. Not just your external, but also your internal perfusion or respiration. So ventilation is the air going in and out, getting the loading of the oxygen sent it through the body. And perfusion is going to be, it's actually getting down to the cellular level and being offloaded and unloaded. So is there going to be a mismatch between the amount of oxygen you're ventilating in and out versus what you're actually getting to the cellular level? That's what we're talking about when we say ventilation respiratory ratio mismatch. Air and blood are meant to be directed to the same place at the same time. Ventilation and perfusion must be matched. Failure to match is the cause for most abnormalities of oxygen-carbon dioxide exchange. Normal resting minute volume is 6 liters per minute. We averagely all breathe in and out 6 liters of O2 in a minute. Pulmonary artery flow is approximately 5 liters. Ventilation to the perfusion ratio is 4 to 5 liters per minute, or 0.8 a minute. Please stand by for a second, guys. Sorry about that. I had to do something with my other computer there. Factors affecting the pulmonary ventilation is maintaining a patient's airway. Maintaining a patient's airway is crucial. If they don't have an airway, you don't get a breath, you will die. It's very crucial. You have your different factors that might cause your going on inside your body. You're going to be an infection, allergic reactions, unresponsive because if there's a tongue obstruction. Your extrinsic factors are going to be trauma, things happen outside your body, foreign body airway obstruction, which is going to be happening, something that came from the outside into your body, it's invading your body, it's excluding your airway. Small kids would be like balls, bouncy balls. What do you call those things? Anything you think of, any little cars, anything that you notice, anybody under the age of 3 or 4, they pick it up, it goes where? Right, it goes right directly to their mouth. You are correct. And it can cause a foreign body obstruction. External factors decrease atmospheric pressures at high altitudes. That's why you go up in a plane and it says it has to be pressurized, or there's a problem. When you go decrease atmospheric pressures at high altitudes, if you're a climber, you're climbing, you can start having trouble breathing at pretty high altitudes because the air is thinner. Different internal factors, you might have pneumonia or COPD, chronic obstructive pulmonary disease. You might have circulatory compromise, trauma injuries, trauma emergencies typically obstruct blood flow to individual cells and tissues. You might have a pulmonary embolism, a tension pneumothorax, an open pneumothorax, hemothorax or hemopneumothorax. Pulmonary embolism is an embolism or a blood clot in the lungs. Tension pneumothorax Pneumo is air, thorax is chest cavity or lungs. So this is pneumothorax, excuse me, in the chest, I'm sorry. So pneumos air in the chest cavity. Do you need air in the chest cavity? You need air in the lungs, not in the chest cavity itself. But attention pneumothorax will be a problem because you have air building up where it's escaping from the lungs and getting into the chest cavity behind it. An open pneumothorax would be an injury like a gunshot wound through the chest wall into the lungs, or a stab wound. Hemothorax, thorax again is chest wall. Hemo is blood, so it's blood in the chest wall. Blood is supposed to be in your veins, in your arteries, no other place. Air goes in and out, blood goes round and round. Any change in that is a problem. Please remember that. Air goes in and out, blood goes round and round, and any other change of that is a problem. So you have hemothorax, which is blood in the chest area. Then you have pneumothorax. Pneumothorax is air, hemothorax is blood. So you have blood and air in the chest cavity behind the lungs because one of your lungs is collapsed from some sort of trauma going on. Other causes include blood loss, anemia, hypovolemic shock, and vasodilation shock. Recognize your ability to breathe. Recognizing adequate breathing. The normal person is breathing the normal adult is breathing between 12 and 20 breaths per minute. Regular pattern of inhalation and exhalation. There's bilateral clear and equal breath sounds, which we'll talk about more later. You have regular chest rise and fall, regular equal chest rise and fall, and adequate depth or tidal volume, the amount of air you're taking in and breathing out. Also some things to how to recognize abnormal breathing in a patient. People breathing less than 12 breaths per minute. People breathing more than 20 breaths per minute. Either way, this could be a problem. Excuse me. Inadequate rhythm. Diminished, which means you can't hear them as good. Diminished or absent or noisy auscultated breath sounds. Auscultation, or auscultated here, that means listening with a stethoscope. So if you have diminished breath sounds, absent or noisy breath sounds when you're listening to somebody's breath sounds, there's a problem. Reduced flow of expired air at the nose and mouth. Unequal and inadequate chest expansion. Increased effort of breathing. Someone talking, I'm having trouble breathing. And that's somebody who's not getting the air that they really need to be getting to maintain an open airway. It's a problem. Shallow depth of their breathing. Some are breathing very, very shallow. Skin that is pale, which is palish in color, whitish color, gray color. Cyanotic is blue. You're not supposed to be blue unless you're a Smurf or a member of the Blue Man group. But if you are blue, there's a problem. Cool and moist. Pale, white, and gray. Cyanotic means blue. Cool and moist. Skin pulling in around the ribs and above the clavicles during inspiration. Kussmaul breathing. A patient may appear to be breathing after the heart is stopped, called agonal respirations. Then change stroke respirations are often seen in stroke patients and head injury patients. This is different breathing patterns at a minute level. Ataxic respirations, irregular and unidentifiable pattern, may follow serious head injuries. Kussmaul respirations, they're deep, gasping respirations associated with metabolic and toxic disorders. Patients with inadequate breathing need to be treated immediately with a bag valve mask. Respiration is the actual exchange of oxygen and carbon dioxide at the tissue level. Even though the patient may be ventilating appropriately, respiration may be compromised. Like I said earlier, respiration is the air going in and out. Ventilation is the air going in and out. Respiration is the exchange of the oxygen and carbon dioxide and the external respiration at the lungs, internal respiration at the cellular level. Skin color level consciousness are excellent indicators for respiration. Also consider oxygenations. Pulse oximetry is the method to assess this. This can be seen in skill 9.1. We'll talk about that later and show you some different things. So how do we open an airway? If airway is maintaining an airway is one of the biggest things we need to do in EMS, then we need to know how to do it. So what is it? It's actually manually opening somebody's airway when that airway is closed or not working correctly. Emergency medical care begins with assuring an open airway or patent airway. So your rapid assessment whether the patient is unconscious, rapidly assess whether the patient is unconscious and they have an open airway and if they're breathing adequately. If they're not, position the patient correctly. Supine position is the most effective. Then if the unconscious patient should be moved to the unit, most common airway obstruction is the tongue. To get the tongue out of the way, if this is a patient who is a medical patient, has had no history of trauma, then we can use the head tilt chin lift. If it is a trauma patient, we're going to use a modified jaw thrust, and we'll see pictures of those in a couple minutes here coming up. Other causes of airway obstruction other than the tongue can be dentures. Dentures see a lot of denture problems. Whether you get stuck out there and people can't get them where they're supposed to be going. Blood, vomitus, mucus, food, and other foreign objects. So the head tilt chin lift maneuver. This maneuver will open an airway of most patients for patients who have not sustained or are not suspected of having a neck trauma or any type of trauma. Follow these few steps. For the patient supine, position yourself beside the patient's head. Place the heel of one hand on their forehead. Apply firm backwards pressure with the palm of your hand. Placing the fingertips of the other hand under the lower jaw. Lift the chin upward with the entire lower jaw. I thought it would work, but it's not going to work. Alright, sometimes they work, sometimes they don't. I can get you guys a video so you can be watching for it. I'll put it on the Edmodo for you. If you suspect a cervical spine injury, use this maneuver. It's called the jaw thrust maneuver. To do this, you need to follow the following steps. Kneel above the patient's head. Place your fingers behind the angle of the lower jaw and move the jaw upward. Use your thumbs to help position the jaw. Nice picture of that. So your fingers are up under the jawline here, and you're pulling up on the patient's jawline. Use a look, listen, and feel technique to assess whether the patient's breathing is returned. Look, listen, and feel. You put your head and your ear right down below, right next to the patient's mouth, looking down towards their feet. So you can look and watch for chest rise and fall. You can listen for air with your ears, and you can also feel the air on the side of your face. With complete airway obstruction, there will be no air movement. Chest wall movement alone does not indicate adequate breathing is present. So this one looks probably not going to work, but we'll try it anyway. Alright. And we're going to stop there for this first video. If you would, please review this information. We're going to start on the next video with basic airway adjuncts. And you guys have a good evening or good morning. I will talk to you guys later. Thank you. Bye. Any questions, please don't forget to either email me at ccradle@wcpss.net or on Edmodo. Thanks.